This episode of the GeriPal podcast is sponsored by the Zuckerberg San Francisco General Hospital Division of Hospital Medicine, which is committed to providing outstanding, compassionate care to all patients, advancing health equity, and fostering excellence in hospital medicine.
They are recruiting for a medical director of palliative care services to lead and grow innovative outpatient and inpatient palliative care programs. This is a unique opportunity to join UCSF's vibrant and renowned faculty, teach and mentor future doctors, and make a lasting impact at one of the nation's leading safety net hospitals. For more details, click on the links in the show notes associated with this podcast.
And on to the show. Welcome to the GeriPal podcast. This is Eric Woodera.
This is Alex Smith.
And Alex, who do we have with us today?
We are delighted to welcome first-time guest, Brent Kious, who is Associate Professor of Psychiatry at the Huntsman Mental Health Institute at the University of Utah. He is both a psychiatrist and a philosopher. Brent, welcome to the GeriPal podcast.
Thanks for having me. Really happy to be here.
And we're delighted to welcome back Dani Chammas, who is a palliative care psychiatrist at UCSF. Dani, welcome back.
Always a pleasure.
It's like your 100th time, Dani, being on the podcast.
Something around that.
And not enough, still.
Not enough. When are you going to launch the Psych Pally podcast?
Maybe it can be a shoot off, like an under the umbrella of GeriPal.
Oh, I love that.
More to talk about there.
Well, we have a lot to talk about today because today we're going to be talking about palliative care and mental illness. But before we jump into that topic, Brent, I think you have a song request for Alex.
Yeah, I do. It is Only Children by the famed Americana artist Jason Isbell. And
why did you pick this song, Brent?
Yeah, because it's a really moving song. And I think relevant to the stuff we're talking about today, because it talks about how the problems of substance abuse and mental illness can affect a person's life. There's a secondary reason, which is that I play guitar a little bit too, but not nearly as well as Alex.
Yeah, right.
And I definitely don't sing as well as him. So I wanted to hear him do it so I could learn something.
There's a tertiary reason too, which is that Alex said no to the first 10 things. Right.
Well, that's because A, we'd done them, or B, Dani was suggesting 3 songs from Frozen 2. Unfortunately, Brent rescued me from having to do a song from Frozen 2. All right, here's a little bit. Walking around at night, fighting my appetite. Every kid in cutoffs could be you. Remember when we used to meet at the bottom of Mobile Street? And what do the broken people do? Are you still taking notes? The Holy Ghost could get inside you, do whatever you put your mind to. Will you read me what you wrote when we were locked outside the building, over-encouraged only children?
That was wonderful. Brent, who sings that again?
Jason Isbell.
Jason Isbell. He's a great folk, Americana kind of. I think the last time we had a request was from Bob Arnold for something about vampires.
Oh?
Yeah. Good artist. Really tasteful. Thank you.
Well, we got a lot to cover today. So we're going to be talking about palliative care for individuals with mental illness. And Dani, when I think about this topic and think about what we're going to be talking about, I see a lot and I hear a lot about integrating psychiatry into palliative care. It's one of the core things that we think about palliative care. Is you got the physical, psychological, social, and spiritual symptoms. So combining those things. I don't think I see a lot about integrating palliative care into psychiatry. When you think about the word palliative psychiatry, is that what we're talking about?
Yeah, it's an important distinction. And I think the evolving terms that try to get at what you're talking about, there's palliative care psychiatry, which you started by referencing. We're pretty familiar with that in palliative care. That's how do we treat the mental health needs of patients with serious medical illness, right? Everything from normative reactions like existential distress, anticipatory grief, to comorbid psychiatric illness like depression, anxiety, PTSD, which we know is really prevalent in our populations, out to sort of patients with severe psychiatric comorbidities, which we probably dropped the ball on more. There's a lot of health discrepancies there and them getting high quality palliative care, but that's palliative care psychiatry. Palliative psychiatry is a distinct idea where the focus of our palliation is the mental illness itself rather than any medical illness. That's our target. And we're generally thinking about treatment-resistant serious mental illness that we think is likely to result in a lot of morbidity and mortality when we talk about it. So in those cases, can we adopt an approach to mental health care that centers primarily around quality of life of patients and their families?
So I got a question. So when we think about palliating the mental illness, isn't a lot of what we do, like when we're treating depression, are we palliating the symptom of that mental illness? Or are we treating the disease? Or how should I think about that?
I might jump in there, right?
Yeah.
Because this is something I've worried about a lot as I've been kind of talking to people who are interested in delineating what palliative psychiatry might actually be. And yeah, there is a way in which everything we do in psychiatry is palliative with respect to the fact that it's aimed at improving symptoms, right? You know, I can't actually think of a single psychiatric illness that I can cure. I wish there was one. But what I can do is achieve enough improvement in somebody's symptoms that we then have kind of remission of the illness from a symptomatic standpoint, even though the underlying biological stuff or the social stuff is potentially still happening. So if you think of palliative care generally as being aimed at symptom remission or improvements in quality of life or maybe improvements in functioning, I feel like kind of all psychiatry is palliative in that way.
Yeah, it's hard because you can also think about it, let's say, because we see palliative heart failure clinics. So people like palliative cardiology clinics where honestly, heart failure management is a lot of symptom management. So it's a lot of palliation. So we hear a very similar thing with that is good palliative care for heart failure is good heart failure management of their symptoms. And how different is it for severe or refractory like depression or any of these things? Your thoughts, Dani?
I mean, yeah, to add though a little bit more nuance, the symptoms that we are choosing to target, the symptoms that we're choosing to decrease in psychiatry tend to be decided upon by us as the providers, right? And so I think there's this one way where if we added palliative care philosophies to all of psychiatry alongside the standard of care, that could be beautiful for everybody because we're going to take in the patient's perspective maybe more than we were trained to. I think it gets more controversial, though, where there are some places where it does become a trade-off, that people are conceptualizing a trade-off between the standard of care and a more palliative approach. And like you said, it's very hard to define the lines of this. We don't have a way of operationalizing which patients qualify. It's incredibly difficult to prognosticate in psychiatry. Lack of response in the past doesn't predict lack of response in the future. So we definitely don't want to use this concept to warp it to inappropriately justify non-treatment or abandonment or letting off the hook a system that isn't great always at meeting people's needs, because this is a really vulnerable patient population. Mm-hmm. But there is a place where, you know, maybe hearing less voices isn't what's most important to my patient. Maybe what's most important to them is not being in a hospital or being employed or staying at home. And that is somewhat of a shift from how we are classically trained to decide which symptoms we focus on in psychiatry. So there's kind of a yes and answer.
Yeah. I was going to ask, Dani, you know, what if we incorporated recovery principles into the practice of psychiatry, right? Where we really center the patient's values and their goals of treatment. I think that muddies the distinction between ordinary psychiatry and palliative psychiatry even more.
Yeah, absolutely. And so I do think that in the places where we can just synergize the two, like I got a grant from ABPN to start teaching primary.
From whom?
Care. The ABP, American Board of Psychiatry and Neurology. It's like our ABIM. But to have a palliative care curriculum for psychiatrists, this is one of our recognized subspecialties. So in ways that we can teach this to psychiatrists so they can synergize these principles, that's wonderful. When we get closer to the extremes where it becomes a trade-off, do we want to keep treating people in our customary ways or not? Well, then I think there's a lot of work to do to create models, to operationalize what we're talking about, to have safeguards in place to try to help people, but also protect people.
Yeah. Well, can I start off with the easy stuff? Like what would be integrating palliative care principles into psychiatry? What does that look like?
I'll take a stab at it.
Yeah.
Right?
Mm-hmm.
So, I mean, I think one thing that people who are grappling with this issue have proposed is just a much greater emphasis on harm reduction and stopping unhelpful treatments. So the unfortunate reality is that a lot of the time, if you have treatment-resistant depression or treatment-resistant schizophrenia or anorexia, and you come to see a psychiatrist, even though you've done everything already, they're going to say, well, let's just try that again, or try something that's very similar to that. And maybe adopting a more palliative orientation would mean a lot of the time saying, we've tried all that stuff and there's not a lot of point in doing it again. What we should focus on is improving your quality of life in maybe non-medical ways.
Yeah, I guess this is the question is, does trying to focus on that mental health disorder and trying to treat that mental health disorder, does that improve quality of life though?
So here's something I'll say though, is that I think there's some implicit bias that goes on with psychiatric illness, not us having issues, but if I were to have posed that question to you in the medical, you would have been like, well, every patient is different. We take the time to understand what quality of life means to them. We take the time to understand their goals, their ethos, their treatment history, and then we make these decisions based on our knowledge of their illness paired with our knowledge of them. Yeah. And something happens when there's like psychiatric illness, which is a ton of different illnesses, right? That we sort of distill it to this one thing that is psychiatric illness, and we
consult psychiatry.
Yeah, like exactly. And so, yeah, for some people, decreasing symptoms, if we can, is really helpful. For some people, it would be really helpful, and we can't. So can we think of other things that we can do to them? That's a very palliative, or do for them. That's a very palliative question. And for other people, they might come to me and say, you know, I've been on this medication. Sure, I'm hearing less voices, but I feel like a zombie. I can't relate to people. I'm tired all the time. Like, give me my voices back over this, right? So...
And it honestly, it doesn't feel that much different. Again, going back to the heart failure example, like we have people who like their number one symptom may be like, I can't go to the bathroom like this much. I got to get some sleep. Like I got to think about changing these meds. So it could be about focusing on underlying disease, like the heart failure, or it could be focusing on more managing the symptom. Like if they're dyspnea, you're kind of maxed out on the diuretics, maybe considering things like opioids. Am I thinking about it correctly?
Yeah. I mean, I think
reasonable analogy.
I think the trickier thing that comes up, and I would love to hear Brent's thoughts, but the trickier thing that comes up in psychiatry is, number one, our prognostication isn't as solid as it is in medical things. So it's harder for me to say, like, this person might not get a lot better if I let them forego this. That, you know, with heart failure, you know how good it might get in general. And number two is there's always this question about capacity in the setting of psychiatry. And some people will have decision-making capacity, some won't. But when we say there's not an algorithm, the compass is determined by the patient. Well, what does that mean for a patient who doesn't have decision-making capacity?
So the depression, the bipolar disease could be impacting somebody's ability to make an autonomous medical decision. So that, as opposed to like heart failure, unless they're delirious, doesn't really affect their decision-making capacity. Again, unless they're delirious. Like here, the disease actually can.
Yeah. Brent?
Go ahead, Brent.
I want to insert something there about capacity, though, and I'm sure that all of you are ultimately aware of this. A person with bipolar disorder in a manic episode or a severe psychotic episode in schizophrenia might still have capacity to make a lot of different decisions.
Yeah.
So it really depends on how their illness and the particular impairments that are associated with it bear on their decision making. I mean, we frequently admit people with severe psychosis to our inpatient hospital on a voluntary basis, and we have detailed discussions with them about the risks and benefits of treatment, and they decide what they want, right?
Mm-hmm.
They have
Brent,
to
I
ask.
think speaking to the fact that we are talking about such a massive array of illnesses, of presentations, of symptom severity, and trying to speak in generalizations, right? Which is so hard to do.
It's really hard. I think the capacity issue comes to a head in particular when you're talking about the desire to die and or the expressed wish or expressions of, suicidal ideation is the formal term. Is that right? When you're talking about palliative care and psychiatry?
I think really anything that is a choice, like hospice or an expressed like hastened wish to death, then we're always thinking about capacity. But the wish for hastened death is a really interesting one because it's like there's so many considerations. There's the legality, there's the morals of ourselves and our patients. Then there's the ethics, and they're not always aligned depending on your geography, who you are as an individual, the ethical parameter you're considering. So here in California, if somebody uses end-of-life options, wants to die, and I'm doing their mental health assessment, I do have to make sure that they have decision-making capacity. That's like a hard barrier, which has a clear definition and has really big implications for access to MAID for people with, dementia or serious mental illness without capacity. But the other piece of our law says that the patient must not be suffering from impaired judgment due to a mental disorder.
Mm-hmm.
That's a tricky one, right? So having depression isn't going to be a contraindication to MAID. You might still be able to get it, but the law does expect me to assess if their request, whether or not it's primarily driven by an untreated or an unmanaged mental health condition. And it's not straightforward. That's a really hard thing for me to assess. We know that the frequency of psychiatric symptoms is higher in people who make these requests, but we also know that when we treat the mental health condition, sometimes the request resolves. Sometimes the request doesn't resolve. So there's a lot of subjectivity there. And even to add to the nuance, what if I do think that it is motivated by a primary mental health condition, but I don't think there's a good chance that mental health condition is going to resolve before they die?
Yeah. Brent, you thought quite a bit about this. What are your thoughts?
Yeah, I mean, I would add to what Dani has said, which I think is entirely right, that this becomes especially hard when we talk about people with severe and treatment refractory psychiatric conditions that are often marked by suicidal ideation. So someone with major depressive disorder where suicidal ideation has been a longstanding symptom for them, or somebody with borderline personality disorder. And those are conditions where people have, in fact, received medical aid in dying or other kinds of palliative death hastening interventions. I have a kind of philosophical stance on this, right? Which is something like this. People want to ask, is the suicidal ideation, the desire to die, due to the illness, or is it the authentic wish of the person? I think that is a nonsense question. So I'm just going to say that.
Yeah.
And the reason I think it's a nonsense question is that I don't really think that we have any way of establishing authenticity in especially hard cases where somebody has had very long-standing desires, because the usual things we would think about as marking authenticity, like a change in what you want that seems sudden or inexplicable, just don't really apply. So I think what we ought to ask in these situations is, does the person's desire to die make sense to us? And in a lot of the cases Dani's talking about, where maybe somebody is asking for medical aid and dying for their cancer, but they also have depression, if we treat the depression and their outlook on life changes a lot and they're not interested in dying anymore, that's a case where their request to die doesn't really make sense in some fundamental way. They still have good reasons for going on, probably. But where that wish is persistent, I feel like we can also often understand where the wish is coming from, given what's happening with the patient.
I do want to stick with this topic, and I also want to acknowledge that, and interested in your thoughts on this. My read is that the biggest issues in palliative care and psychiatry are really sort of the first things that we've talked about. People who have serious medical illness and have psychiatric complications as a result, or people who have coexisting psychiatric illness and serious medical illness. And that this issue of MAID sort of brings things, it's interesting to talk about for a variety of reasons.
It's the fringe.
But it is not the major issue by which the flag's tentpole issue, I think is the phrase, by which we should be organizing like palliative care psychiatry around. Is that fair to say? Or what, what do you think?
Important though, because I actually think we get a ton of requests for hasten death, and we are still working on how to best understand like where it's coming from. And there's a lot of non-controversial waters that come before MAID that we can think about. I think the other piece is that different countries, different states, they don't have the same requirements that we have, right? And who's making these decisions? Some people don't. In Canada, as long as you have a terminal illness, it doesn't matter if your depression was driving the request, right? And so some of us are more driven by the doing no harm, others more driven by autonomy and justice. And I think it puts us as humans in the provider role in a really difficult spot, trying to reconcile the care that we're giving and trying to figure out what is appropriate. And you're right, it is on a continuum, because how about DNR, DNI? If somebody is very depressed and suicidal, are they allowed to say that they want to be DNR, DNI? We let them. But what if a few rounds of ECT later, they wouldn't want that? And, in the interim, they code.
Yeah.
I'll just note, in our hospital, we don't always let people who have been suicidal recently, and this is a psychiatric hospital, of course, be DNR, DNI, right? So our policy is that's not necessarily guaranteed.
Yeah, it's a struggle because it gets to this question, what if people would change their mind in the future if we just did X, right? So if you talk to somebody and they adamantly don't want an amputation, and you're going to get it, because I know the data would suggest people's quality of life is generally viewed better post-amputation than people think it's going to be pre-amputation. So we're just going to do this to you because we know better. Is that different than this?
Different than potentially allowing somebody who has a serious psychiatric condition to access medical aid in dying, you mean?
No, this idea that if we just convince them to, or if we just forcibly did something to them, and their thoughts on this subject would change post-intervention, post-psychiatric treatment, because their long-standing chronic depression, this hope that it's going to get better,
I think the difficult part here when we're talking about decision-making and judgment in the setting of mental illness being the target is that it's quite possible that someone has capacity, but it's very hard to say that mental illness isn't impacting people's judgment, people's outlook. Yeah. It's different than having a leg issue, but being fully the way you're viewing the world is still consistent to who you are, versus being in an episode of depression where there's a complete lens on your view of the world that can go away. It makes it really hard. And I think what we're all struggling with here is this is very gray territory, right? Yeah. We want clear boundaries and clear definitions, and we try to impose them, but where does somebody's mental illness and somebody's personhood, what's the line between those two? What if you've been depressed your whole life? Is it a part of your personhood? It doesn't all fit into these very clear separations.
Yeah. Just to build on that, and then we'll go to Brent on this. One of the reasons that this issue of medical aid in dying for people who have severe psychiatric illness is so interesting is because of the issues that come to bear and the competing ethical concerns that arise in these situations. And I'd add one more to the mix, which is, we have a friend who evaluated somebody for medical aid in dying and felt seriously moral distress about this request. And this is a person who had serious refractory mental illness, been treated for years, decades, and just didn't feel like this provider could sleep at night if they were to prescribe medical aid in dying, because they would feel like they were killing this person and not helping that patient to gain control over the inevitable end of their life. So that moral distress is yet another factor that comes up for the providers. And Dani, I think you do some evaluations that may have come up for you as well. But Brent, I want to go to you on this for further thoughts.
So, one thing I wanted to say in response to something Eric said earlier is there's a way in which psychiatry is often in the business of making people do things that we think are going to help them feel better in the long run.
Yeah.
And it's a little less common in California than it is in Utah, but we treat a fair number of our patients involuntarily, and some of the time they thank us for it afterwards, not always.
Yeah.
I think when we're talking about the palliative realm in psychiatry, though, those kinds of considerations aren't really on the table because we're talking about people for whom typical involuntary treatments are very, very unlikely to be helpful anyway because they haven't helped so far.
Mm-hmm. They've often received years, if not decades, of treatment.
Yeah.
Yeah.
I have a thought on the moral distress, but I also feel like we're pulling ourselves into like this idea of terminal mental illness. Is that actually a thing? But
yes, we should talk about that too.
Ask that question.
Okay, well, let me just quickly to get to Alex's question about moral distress. I want to expand it from just the MAID area. I think it's very present in MAID. I think it's present in this whole entire array where we are left as providers grappling with, did I try enough things for this person? Has society failed to reach this person's needs? Are there restrictions that are making me not give this person some kind of peace that I give that option to other people? What if there's a clinician out there that's better equipped or trained than I am to tend to this person? Not long ago, I was attending on an inpatient psych unit, straight psychiatry, and there was a patient. She was incredibly psychotic, and she was lying on a bed in the corner of a room, completely alone, moaning with pain from her cancer. And it was heartbreaking to witness. And I remember the on-call resident had this huge wave of relief when he found out that I was palliative care trained, because he didn't have to grapple with the fact that he was watching a distress that he didn't feel totally equipped to address. So there's examples across the board where providers have moral distress. We haven't thought through a lot of these on ourselves.
Yeah. Yeah, I guess, another source of moral distress is going to this question. Is this person really dying? Do they have a terminal illness from this depression, from this anorexia, from this bipolar disease?
This gets the question. Is this a thing? Terminal mental illness.
Because I do think that I've actually had patients like this, really bad depression, refractory.
Mm-hmm.
And the question is, hospice comes up, and I have to think, wait, does this person meet the prognostic requirement that we used to call terminal in hospice, which is very quick, clearly labeled 6 months or less?
And there are a couple cases that we can talk about because they've been in the lay press. There's a Boget's case of patient with anorexia who utilized medical aid in dying. And there's another case, a woman named Naomi, who was in the New York Times. We'll have links to those cases in our show notes. Naomi also had anorexia. And in both cases, decades of treatment.
So in cancer, we can say, we can pull up studies. This person has metastatic pancreatic cancer, 99.9% sure. Can we say that?
Do you want to go first or second? I've got thoughts.
Well, I've got thoughts. Maybe I'll jump in. I mean, I think that the idea of terminal mental illness is a medico-legal nicety that allows us or allows some psychiatrists or physicians to provide medical aid in dying to persons with severe and treatment refractory mental illness. Because it's very clear, even in the cases like Boget's, the illness is not terminal in the way pancreatic cancer is terminal. Pancreatic cancer is going to kill you regardless of what we do. Even with the best and most sophisticated medical interventions, death is going to happen relatively soon. And with anorexia nervosa, that's really not the case, even in the most treatment refractory cases, because providing nutrition is always going to be an option. So I feel like that's kind of a red herring. And
is it though? Because you could have somebody with, pancreatic cancer, hasn't been treated yet, decides they don't want treatment. Their prognosis without treatment is less than 6 months. But if they got treatment, it could be more.
Yeah, but right. And so I think this gets to the really critical issue. We look at that person with pancreatic cancer who has a prognosis less than 6 months because they've decided not to get treatment. And the reason we're comfortable saying they have terminal illness, I think, is that we can understand why they would make the choice they have made. Treatment would buy them a couple of extra months, but they'd be painful, uncomfortable, et cetera. It's very reasonable for them to say, I'd like to forego treatment, even if that means a little less life.
Yeah.
And I think that's the same standard we should apply to psychiatric illness without use of the word terminal, which is just obscuring things, right? What we really ought to ask is, are things going badly enough for you, given all the interventions that you have tried, and how likely any additional interventions would be to help you, that your wish to receive something like medical aid in dying or palliative sedation, or to use VSED, makes sense?
Yeah.
Although I would say, Brent, I'm with you, and I do think that some people would understand why Alyssa made the request that she did. She had
Alyssa Bogutz. Yeah.
Yes.
Just to be clear for our listeners.
And we'll have links to that in our show notes. So if you're interested in reading,
Again, it's in the lay press. You can read about it. This is not revealing anything. Yeah.
No, but what I want to add to this terminal mental illness thing, because I think it's getting a lot of traction and excitement, and this is such a fraught term. It's so controversial in ways that are hard to reconcile. There are some people who feel incredibly strongly that it should not be used. It's an inappropriate term. And I was even nervous to talk on this podcast today because I know it's going to elicit strong and very valid feelings in some people. But some of the nuance I would want to point out is that, like Brent mentioned, first of all, this is not a diagnosis. It's not a defined entity in the DSM. It's not something that we have, statistics or anything around. When people talk about terminal mental illness, it's very different than how we use the word terminal in medical illness. And I think they generally do really mean patients with serious mental illness for whom the treatments we have available are unable to, we think, ever help them achieve meaningful quality of life or symptom control. And there are two deeply important perspectives here. On the one hand, we don't have an empiric way to classify what's an untreatable mental illness. Again, some people don't respond for years and then do when we try something else. And in this really vulnerable population, we don't want to disenfranchise people from treatment that might make a difference. In psychiatry, Brent referenced this, we often have seen times when a patient says, I don't want treatment, and we compel them to get it. And then they profoundly improved. So there's a risk to labeling somebody's mental illness untreatable. And on the other hand, in psychiatry, we've also seen some people who get treatment their whole life, but continue to suffer unrelentingly. So this other very valid perspective is to say, we don't want people to suffer if we don't have the tools to help them. Refractory illness can be so impactful on quality of life, and that can get compounded if we're compelling people to have treatments that they may experience as harmful or as traumatizing without necessarily having benefit. So I think the philosophical debate is really around the concept of untreatable mental illness. Is there untreatable mental illness? And if it is, how do we know that it is? And that's not an empirically answered question at that point. I don't even know if it's an empirically answerable question.
Eric, you've thought about sort of different standards, and you wrote, I think, with Josh Briscoe in response to a piece by, was it Thaddeus Pope?
Yeah, there's
about VSED.
JAG's article on Thaddeus Pope.
And we were actually going to have Thaddeus on, and you can talk, and with Josh.
Because I don't remember what I wrote.
Right. I'm going to ask you about it anyway. But I think in response, you wrote something that is applicable here, and that is about the standards by which we should allow somebody to be eligible for medical aid in dying. And you wrote about, you notice that in the terminology in all statutes across, in the United States, at least in the state statutes, they include the words irreversible and incurable. Could you say more about that in relation to?
Yeah, I mean, I think it gets to this question about, Brent, I forgot what you called it, like medical legal nicety around terminal illness. But it's more than that. It's part of the law. Like if you were going to follow the law of medical aid in dying, that somebody has to have an incurable, irreversible illness and a prognosis of less than 6 months. And the question is, does, like if you were just not arguing it whether or not that's the right thing, we did a whole nother podcast, folks in Canada, where it's moved away from that. But if you were going to follow the law, does any serious mental health illness, can we ever claim that?
That there would be a psychiatric illness where, regardless of what we do, the prognosis is less than 6 months.
Yeah, I hear that potentially that we can say it's maybe irreversible or incurable. We've tried everything, probably to a similar extent that it's the case for other medical illnesses, ALS or different kinds of cancer. But can we say, oh yeah, it's less than 6 months?
I'd be curious to hear what Dani has to say about this, but I really don't think so. In the absence of some significant somatic medical comorbidities, I don't think that psychiatric illnesses typically produce death directly.
Yeah.
If we do all the things that we could do to provide care for the patient's basic needs, right? I mean, if somebody has really bad depression and they stop eating and nobody bothers to feed them or make sure that they eat, then yeah, they could die. But that's not really just the depression. It's a lot of other things that are happening too.
Yeah. Dani?
I was really happy you asked Brent that question.
That's your answer?
I generally agree that there's not a psychiatric illness that if we did nothing, that a person would die within 6 months. It's just, how far will we go? Like, if there's somebody with anorexia who's not going to eat, are we okay keeping them hospitalized against their will in perpetuity with feeding tubes, getting nutrition into their bodies? Right? What are we willing to do to a person against their will if they truly don't want it and they truly are refractory? Where is that limit? But from the legality perspective, the strict legality perspective, it's hard for me to conceptualize any mental illness that I could say without treatment you would die within 6 months from.
Yeah, so I think we can all agree that absolutely people with, maybe we could call it something like severe refractory mental illness, to avoid the term terminal and characterize it more by its lack of response to treatment. People with severe refractory mental illness should have the option of having a palliative approach to treatment. In fact, most of their treatment is palliative by nature. And that, two, there are patients with severe refractory mental illness who might be eligible for hospice. They might have a condition which is likely to result in death within 6 months if the disease takes its usual course, but they don't meet the definition for medical aid in dying, which requires that you have a incurable, irreversible, right? Much stronger language here, and are able to consent. Right? In hospice, you don't have to consent. You can have a surrogate decision maker make the decision for you. You cannot do that for medical aid in dying. So that we can and should have different layers of eligibility for these different services. Palliative care, much lower bar. Hospice, higher bar. Medical aid in dying, much higher bar.
I said that in my article? I sound smart.
Yeah, it's good.
I'm a smart guy, said that. Well, and this is like where the Alyssa Boget's educational fund that we have at AHPM came from, right? She did elect to go into hospice because she did not want more suffering, more treatment for her anorexia. And the family found that the hospice providers were very kind and very thoughtful, but they didn't feel like they had the skills or the nuance to tend to what she and the family needed psychologically to understand this construct of the fact that her death was secondary to her really severe mental illness. And I think that totally highlights the impact of siloing, right? Psychiatry and palliative care have so much pertinence to each other, but they're often incredibly siloed from each other. And there isn't as much collaboration as you would think. And palliative care is a psychiatric subspecialty. And so why are we not educating psychiatrists in palliative care? Why are we not educating palliative care doctors in psychiatry? And why have we not built systems that bring those silos together so that this really huge need can be better tended to in people?
I'm convinced, Dani. I want to go do my palliative medicine fellowship now. I can't. My wife won't let me.
We'll take it. I love it.
I'm going to go back to the initial question. I know we still a lot to cover, but like, what does that actually look like? Because I think we asked this in the beginning, we just touched upon it. What does that palliative approach to these serious mental illness? Like, what are the things that you're trying to teach?
Yeah, what's in the curriculum that you're developing for the American Board of Psychiatric something or other?
I'll tell you once I've developed it.
That's a good. That's fair. That's fair.
There's such a spectrum, right? Like it's crazy what a big thing we're talking about, because I think that psychiatrists need bread and butter palliative care. We know people with serious mental illness are not getting palliative care, so they need the primary palliative care. Just like the goals of care and those types of things need to be there. We know that they might be the people giving primary palliative care, and then it's all the way to the extreme, though, of like, what hospice team do you know of has been taught how to manage someone who's psychotic in a way that's going to feel calming to them, or how to manage somebody who has a really severe personality disorder that's getting completely triggered in their death and their loss of control in a way that might be containing to them. And so it's really all the way from like what psychiatrists are doing with their patients to what we're doing with our patients, because nothing fits particularly into a box.
Yeah, and I'll say, we work clinically at the VA doing inpatient palliative care consults. I would say, I'm interested in whether you think this is accurate, like 80 to 90% of patients we see have a psychiatric diagnosis. These are people with serious
PTSD,
mental illness, PTSD, depression, anxiety, very, very common, or even if it's not a formal diagnosis, they have depressive symptoms
or anxious symptoms.
They have demoralization. All of these things are incredibly common, and they're issues that we rely on our interdisciplinary team to help us with, And I think that's okay, but a lot of people out there who are working without the benefits of an interdisciplinary team. We don't have a psychiatrist on our team, for example. We have psychologists, we have social worker who's very attuned to these issues. We do not have a psychiatrist.
But we have consultants. We have psychiatrists, but not palliative care psychiatrists. Did I get that right, Dani? Yeah? Palliative care psychiatrists, not palliative psychiatrists.
I love it. These are evolving terms. None of these are in a textbook somewhere, but you're witnessing us trying to organize around a really vast need. And yes, so you don't have a palliative care psychiatrist there, and most psychiatry units don't have a palliative psychiatrist.
Mm.
Yeah.
And there's low-hanging fruit of, why would a palliative care fellow not do a psychiatry rotation? If we're all agreeing that the majority of our patients have these struggles, why would a psychiatrist not do a palliative care rotation if it's a recognized psychiatric subspecialty? Those are, in my mind, the lower hanging fruits. And then just systematically, can we take away the divide?
But it is different I can see that psychiatrists doing palliative care rotation, but really for the palliative care fellow, what you're interested in doing is in a palliative psychiatry rotation. It's not just doing a psychiatry rotation, but doing the thing in the subspecialty that you're interested in. It's like you're not just going to send them to a cards clinic. You're going to send them to maybe a palliative cardiology clinic.
Mm. Yes. And the moment that we have evolved enough since to all have palliative care psychiatry clinics and palliative.
Are there any?
Palliative care psychiatry clinics, yes. I think PsychoOnc is really a form of a palliative care psychiatry clinic, right? But that's specific to Cancer Center. Dan Shalev, for example, is at Cornell, has now a pilot where he's trained in psychiatry and palliative care. He has embedded clinics within palliative care, larger palliative care clinics, where he tends to the psychiatric needs of the palliative care population.
But the population that we're talking about for this podcast, people with serious mental illness, are there palliative care clinics for them?
No, it doesn't. There's some amazing providers out there who are integrating these philosophies in what they do, because they space a lot, but no, it doesn't exist. Yeah.
I don't actually think that there are any people out there, maybe there are some internationally that I don't know, who are practicing palliative psychiatry as the bulk of what they do clinically. Yeah, maybe all of us are to some extent doing some palliative interventions in our ordinary psychiatric practice. I hope so.
Yeah, that primary palliative care in psychiatry versus like the specialty palliative care in psychiatry.
Right.
And I think we need to start like labeling, though. I think you're right. Like, what would the impact be if we labeled some of the things that we're doing as palliative, just in terms of our mindset of understanding why we're doing what we're doing?
See, I think that is a really hard question and actually needs some research because, on the one hand, there could be a real rhetorical benefit from doing that, right? Because it would change the way we think about what we're doing in much the way that like maybe talking about the recovery model can help reorient people's goals and the way they're approaching
This
care.
is the second time I heard the recovery model. Real quick, what is the recovery model? If you can do it in a sentence.
The recovery model is something that's been around for decades now, where basically recovery is defined as working towards the patient's self-defined goals with the support of often a multidisciplinary treatment team. So recovery for one person might mean I was able to get a job. And recovery for another person might mean my depression was reduced by 50%, right? So it's just a very patient-centric approach to psychiatric care and mental health care generally.
Yeah, I think these terms are really important and that there's a risk, right? Like we've done some beating up on the term palliative chemotherapy, when we were a blog and then sometimes on the podcast, On the one hand, it has the potential to like help people think about care in terms of the patient's goals. Mm-hmm. On the other hand, it may dilute what palliative care means.
I would argue, though, it has nothing to do with patients' goals because when people use it, it just means non-curative chemotherapy.
Exactly.
It's like using palliative care for a psychiatry. It's just non-curative psychiatry.
Is everything there?
Yeah.
I give one closing thought. I'm trying to put myself in the mindset of the people who are listening to this podcast out there. Thank you for listening if you did. But it might feel like we posed more questions than gave answers, and that we were going around it. And if it feels like that to you, if you feel like your clarity is less, I would say that that's success, that's a good thing, because these are not easy questions. If they were, we would have them answered. I think we really need to spend a lot more time pondering the gray, breaking down the silos so that the expertise, we don't even have an eating disorder specialist here today, right? So that the expertise can come together, increasing our education for the sake of our patients, for the sake of ourselves. So thanks for being in the gray with us all.
I love that. Brent, any other closing thoughts for you as far as where you see this all going?
I just totally agree with what Dani said. I think that these are really complicated issues. And I just have to acknowledge that I always kind of find myself wanting to sit on the fence. I think there's a lot of things you can say in favor of palliative psychiatry or medical aid in dying for psychiatric illness, but a lot of things about both of those topics that really give me pause, which would really make me worried about, bringing medical aid in dying to my patients, for example.
Mm-hmm. Well, Brent, Dani, I want to thank you both for being on this podcast. But before we end, is it only children? Yep. Only children.
Cold coffee on the fire escape. We bet it all on a demo tape. We still had something left to steal. Remember when we took too much to get a little of that human touch? Hand to mouth and reel to reel. Are you still taking notes? Hydrocodone in your backpack. Maybe these words will hold the beast back. Will you read me what you wrote? The one I said you stole from Dylan. Over-encouraged only children.
Dani, Brent, thanks for joining us on this podcast.
For having us.
Thanks for having us. Awesome.
And to all of our listeners, thank you for your continued support. We'd also like to thank everybody who's donated over $250 to the podcast over the last year, including
Daryl Owens, Craig China, Mike Steinman and Dorothy Richmond, Diane Meyer, Matt Schuster, Harry Hahn, Elizabeth Chung, Wendy Peltier, Kelly Straight, Jeffrey Galbraith, Ron Sabar, Rebecca Goldstein, Anna Lynch, Deborah and Jeffrey Larson, Krista Masak, Ed Martin, Stuart Oserman, Mo Rizawi, Rochelle Bernacki, Daryl Owens, Mark Wren, Richard Lewis, John Bielenson, James Tulsky, Elizabeth Cobbs, Christopher Heck, Meg Walhagen, Chris Jones. Thank you all.